Good evening, everyone, and welcome to tonight's webinar. I'd like to thank all of you for joining us today. Our planned topic today was advances in ischemic and hemorrhagic stroke interventions. However, due to just the sheer nature of the topics, we are going to split our topics in two this time. So we will be doing advances in ischemic strokes, and then part two will then be hemorrhagic stroke interventions. So please make sure to tune in and join us for part two of tonight's webinar. Just to introduce our speaker for tonight, our esteemed guest is Professor Victor Mngomezulu. He has over 2 decades experience as a general radiologist and 12 years as a subspecialist in interventional neuroradiology. His professional accomplishments include previously chairing the academic department of radiology at SMU and Wits universities, as well as heading clinical radiology departments at Dr. George Mukhari, Charlotte Maxeke, and Chris Hani Baragwanath Hospital in the last 18 years. He serves in various official capacities in the Colleges of Medicine of South Africa and the HPCSA. He is a director of the first interventional neuroradiology unit in the public sector in Gauteng, which he established at the Wits Academic Complex in 2010, and now provides the state-of-the-art service in the private sector as well. He has vast experience in this field, performing over 200 procedures per annum. These entail endovascular management of brain and spinal conditions, such as intracranial aneurysms, brain and spinal arteriovenous malformations, and fistulas, head and neck trauma embolization, and now management of acute ischemic stroke, as well as general body vascular interventions. He is an adherent long-distance runner with 10 2 oceans and 8 comrades, amongst other marathons, that has been completed thus far. I must say, though, honestly, Prof, I'm more of a walking girl or a standing girl myself. That is very, very accomplished. So I'd like to hand over tonight's webinar to Prof as we talk about ischemic events. Thank you. Prof, over to you.
Hi, Prof. Are you still there?
It says host ask you to start a video, or should I start a video?
Yes, please.
Yes, please. Yes.
Can
Thank
you hear
you,
me?
Prof. Thank you.
But can you hear me? Did you hear what I said?
If you can
Yes,
start again.
yes.
Okay. No, okay, we'll start again. Thank you again, Dr. Mahlangu, clinics and all the organizers really for the kind invitation. And as I was saying that today the focus really is going to be the management of acute ischemic stroke, because this is really one of the big things that have actually happened in neuroradiology in the last 10 to 15 years. So we'll start. So the emergence of interventional neuroradiology has marked a transition from the radiologist, as you know, traditional role as a consultant. Now, interventional neuroradiologists now serve not only as consultants, but as clinicians who assume an active role and responsibility in treatment. So those of us who are involved in neuroradiology, interventional neuroradiology, who are generally can either be neuroradiologists or vascular neurosurgeons, are not just people who just read images as traditionally is known, but we are actually active clinicians who are involved in the management of these patients. Just to give you a quick historical overview, there's been tremendous strides in the last 4 decades in the field of interventional neuroradiology. For instance, in seminal events, the first cerebral angiogram known was performed in 1927. And this field, as you can see, is a relatively new field, comparatively speaking, with the introduction of INR as a radiology subspecialty only in 1980. So you can see it's a relatively new specialty. Throughout the years, there's been tremendous advances in this field, and I'll just focus on the seminal events. I think between 2002 and 2005, a seminal trial called the ISET, International Subarachnoid Trial, was performed, which basically established interventional neuroradiology as a preferable way of managing intracranial aneurysms compared to traditional surgical clipping or open surgery. And in the last decades, from around 2014, multiple clinical trials came in, which were in favor of mechanical thrombectomy in the management of acute ischemic stroke. So neurointervention evolution really has been largely due to, now that we have access to very sophisticated neurointerventional cath labs, biplane flat panel with capabilities such as 3D imaging, roadmap, DynaCT, and so on, which really enabled us to be able to perform all these intricate and delicate procedures. And also the development of the devices that we use, coils, catheters, balloon stents, all these things, fancy things that we manage to actually navigate the neurovascular system with. Through these developments, navigation of the cerebral and spinal vasculature is now de rigueur. Now we are able to treat intracranial aneurysms, vascular malformations, both brain and dural and spine, cerebral revascularations, stent angioplasty for intracranial atherosclerotic disease, and acute ischemic stroke, which is the focus of our discussion today, pre-op embolization of head and neck tumors, and craniofacial trauma and epistaxis management. So stroke by definition can be defined as an acute central nervous system injury with an abrupt onset, traditionally classified as a neurological deficit for greater than 24 hours. Just to illustrate what a big public health problem stroke is, one of the recent papers published in 2023 in Stroke, titled Projected Global Trends in Ischemic Stroke Incidence, the Death and Disability Adjusted Life Years from 2020 to 2030, demonstrated that by about 1999, stroke and it continues to be the second leading cause of death globally, with about 11.6% of death attributed to stroke. In 1999, 7.9 million people suffered ischemic stroke, and 63.48 million disability-adjusted life years, accompanied by about 3.29 million deaths, which has actually since increased when one looks at the recent papers. This paper predicted that between 2020 and 2030, people more than 25 years will have a 24.9 lifetime risk of developing a stroke. We know that the world today is suffering from epidemic of non-communicable diseases, and stroke is really one of the major problems. There's a projected increase in all ages and both sexes. And incidentally, the fastest increases in this paper were found to be in Cyprus, Palestine, and South Africa had the honor of being third in the list as one of the countries that actually have the highest and the fastest increase in ischemic stroke. So we can see that really this is a really major problem. And if no major interventions in terms of prevention are made, this is going to really occupy quite a big proportion of our healthcare efforts. Stroke disease estates simply can be divided into two, mainly ischemic stroke and hemorrhagic stroke. And today's talk is basically focused on ischemic stroke. Acute ischemic stroke basically involve disruption in blood supply to the brain vasculature, which can be due to arterial disease, mainly, which can either be thrombotic, that means a small thrombus moving from elsewhere in the body, such as the heart or the intracranial vasculature, internal carotid arteries, vertebral arteries, basically, which shoot up into the intracranial circulation, including blood supply to the brain. That would be the embolic one. Or thrombotic, it could just be a clot forming due to an underlying disease process within the vessel. There are other causes of stroke, such as hypoperfusion and related vascular diseases, such as vasculitis, arteritis, drugs, infection, vessel dissections. And of course, on the other side, we also can have venous stroke, which really is not the subject for discussion today. This is just an example of the MRI image of an acute left middle cerebral artery stroke on a T2 weighted image and flare sequence, and you can see the signal change suggesting acute stroke. These are just examples of what you might see on a CT scan, and here we can actually see that hypodense cortical base wedge-shaped lesion in the left occipital region, in keeping with a posterior cerebral artery stroke. And on this image, you can see that similar image on the temporal lobe, in keeping with middle cerebral artery stroke. On this image, you can see the similar lesion in the frontal lobe, in keeping with an anterior cerebral, right anterior cerebral artery infarct. These are examples of embolic showers on an MRI. You can see these are multiple and often can be bilateral and not really confined to a particular vascular territory. And these are typical embolic strokes, which can actually be due to embolus shower, typically from heart patients, such as patients with mitral stenosis or atrial fibrillation and so on. These are the kind of picture that you might see. Hypoperfusion stroke may be due largely to many causes that actually reduces blood supply to the brain, which could either be a cardiac arrest or any other thing that is going to lead to brain hypoxia. But more and more, we see patients that might have critical obstruction of such as ICA, internal carotid artery, severe atherosclerotic disease, that actually reduces blood supply to the brain and eventually leading to this kind of infarcts. They tend to affect areas of what you call watershed infarcts, as you can see illustrated in this image here, the cortical border between the anterior cerebral artery and middle cerebral artery, and the internal border zone between the middle cerebral artery and other smaller vessels such as the reticulostriate artery, the anterior and posterior choroidal artery, and so on. And this one you can see at the cortical, at the border between the middle cerebral artery territory and the posterior cerebral artery. So these are areas that are generally vulnerable due to brain hypoperfusion. And this is what you might see on a CT scan with this patient. You can see below here, this is a duplex, color duplex Doppler scan. You can see the common carotid artery, the external carotid artery, and you can see a large clot here obstructing the internal carotid artery. And these are the kind of images that you see in the medial border zone of the brain. And this is another example of a patient with intracranial atherosclerotic disease. You can see a significant critical stenosis of the internal carotid artery on this image, and with the MRI showing those ischemic changes in those critical watershed zones. This is just an example for completeness sake for what you might see in a patient with a venous infarct. As you can see, they are not really necessarily territorial, and they are cortical base, they can be multiple, and the classical cause of this being patients that actually have intracranial venous sinus thrombosis. So what are the treatment options that we have? So there is medical management and medical thrombectomy. Medical management is basically a patient presenting with stroke, and classically a small vessel stroke. This is where we use a TPA or Actilase, and which is basically a clot-busting drug used in stroke patients. For these patients, basically for them to be amenable for this therapy, we need the patient to arrive, or the therapy to be treated within 4 hours. Because once the patient is treated beyond 4 hours, then you begin to have potential complications such as hemorrhage, which may actually result from the stroke. Of course, before the therapy is treated, the stroke has to be confirmed, and we'll go deeper into that later on. But also, more importantly, to exclude contraindications that may actually either increase the patient from hemorrhaging within the brain or may hemorrhage from elsewhere. For instance, a patient that has just had recent surgery, with a surgical wound, and if you give these lytic drugs, they may actually bleed elsewhere. So there are many other complications that, contradictions that we will go into. The focus today really is on mechanical thrombectomy, which basically is what we as interventional neuroradiologists are now able to do, something that was never able to be done before. This procedure uses stent retriever that is placed in the occluded vessel through a catheter placed in the groin. The time window for mechanical thrombectomy is up to 8 hours from the symptoms of onset. Now, if the patient fails IV TPA or they have contraindications, as we've already alluded, they may be eligible for mechanical thrombectomy, particularly if they have a large vessel occlusion, which is accessible with our devices. So let's talk about large vessel occlusions. It's a very common cause of ischemic stroke, accounting to about 40 to 50% of strokes. It's severe, 5 times higher mortality, 3-fold reduction in good outcome. It responds poorly to intravenous thrombolytic therapy. So even if you start patients on TPA, the outcome is generally very poor. As you can see that, if, for instance, a patient that's got a middle cerebral artery occlusion, a large clot, only about 35% of them you might be able to open up that vessel with thrombolytics. If you've got a carotid terminus, only about 10%. So, there is actually very limited management for that. And therefore, this is where mechanical thrombectomy comes in. Successful opening of the artery is associated with improved outcomes, where patients that had a pre-morbid MRI score of 0, we may be able to achieve a MRI score of 0 to 2 with, if it's actually done at the right time and properly. This is just an example, for instance, an angiogram picture of a right internal carotid artery, and this is a right internal carotid artery bifurcating there. That's the anterior cerebral artery. You can see it's open, and you can see a big occlusion here of the middle cerebral artery with poor perfusion of the brain on the side, and this is what you're able to achieve. And basically, that's basically the objective, to be able to go in there, remove whatever is obstructing that, and restore flow to the brain. And if you're able to do that, you can have a good result where the patient basically has a brain that is really as pristine as you can see, and therefore you can actually basically manage this patient successfully without any major sequelae of the stroke. Of course, if we fail to do that, and this is the kind of picture that you might see later on, and of course with various dire consequences, even something like this, which may be fatal, where you actually have hemorrhagic transformation of an infarct, and a patient with a picture like this is unlikely to survive this kind of stroke. So how do we do mechanical thrombectomy? We use stent retrievers, and in our practice, the solitaire stent is really our stent to go to, but there are others such as a Catch Mini, and we use aspiration catheters. So basically, you can either put a stent to pull the clot, or you can actually put a large catheter into the vessel and basically aspirate the clot. This is just a schematic diagram of what we're able to do, putting a stent with a clot there, and basically you are able to actually pull the clot and be able to actually restore flow to that vessel. Clinical data is a clinical evidence, of course. This has become evident in the last, as I said, the last 15, 20 years, multiple trials, as you can see. And these were just basically the early trials that basically established mechanical thrombectomy. Since these early trials, there's been numerous trials that have actually established this therapy. And over the last few years, this has actually gotten better and better. We are now able to treat even the time windows is beginning to widen. When earlier on we were only restricted to treatment patients at 4 hours. Now with mechanical thrombectomy, we're able to, and then it moved to 6 hours. We are now able to treat patients up to about 8.5 hours. And in fact, there are other trials coming in that actually shows that in selected patients, the window period might even be extended. But by and large, at the moment, we're still basically treating patients up to about 8 hours with mechanical thrombectomy. Careful patient selection clearly is critical for to be able to achieve successive results. And really, the big issue about this is timing. IV TPA within 4 hours of onset. And I think really this is really, if there's one thing that we can take away from this discussion, today's talk, is the timing issue, because time really is a critical success factor. The reason why many patients suffer stroke and suffer consequences for stroke, and even though those that actually still arrive in our centers where we're actually able to perform these procedures, is the fact that often patients present late. And sometimes even when patients, they may arrive on time, and if we're not aware and we don't really work very quickly, sometimes patients can lose a lot of time. Remember that for every time a vessel is occluded in the brain, for every minute, about 2 neurons die. So from the time a vessel is occluded, it's actually a race against time. So, and I think that's something that we all need to remember. So for us to be able to treat patients with IV TPA, the patient needs to arrive and the therapy needs to be started within 4.5 hours. Obviously, the earlier the better, and the outcomes are better the earlier you come. Endovascular therapy, generally within 6 hours. And I think that was at the time that this slide was made. Now this has really widened to about 8.5 hours. But we obviously, would like not to wait for 6 or 8 hours. We would like to treat the patient. If you've got a large vessel that's occluded, you can come in within 30 minutes, 30 minutes, 1 hour, 2 hours, the better the outcome is going to be. As opposed to a patient that can still be within the window period, arriving within 6 to 8 hours. Those patients will still have probably some deficits because there will be some areas of the brain that may be permanently damaged, even though you might be able to save a large part of the brain. So time really, really, really is critical. Deficit severity, the neurologist or neurological examination is key with the NIH score, generally at least 8 or higher. Those really will be the ideal patients really that will actually benefit for this treatment. And the selection of the patient should be image-based. Even after we've examined the patient and clinically we can assess this patient for stroke, we need to image and confirm that in fact this patient does have a stroke. CTA, MRA documented clot in the proximal anterior circulation, as well as vessel occlusion. And by large vessel occlusion, we mean either the internal carotid arteries, proximal middle cerebral artery, or M1, but now we can go up to M2. That means the first segment and the second segment of the middle cerebral artery. A1, the proximal segment of the anterior cerebral artery. And with regards to the posterior circulation, we talk about the basilar artery, and we can sometimes go up to the posterior cerebral, the PCA, posterior cerebral arteries. And it's important that we do what we call an aspect score, penumbra imaging, and collateral imaging. And I'll go more into details into these aspects later on. And we should be able to establish that there is actually a core of, even if there is a core of established stroke, we should be able to establish that potentially there is a large part of the brain that may still be ischemic, but that may still be amenable for treatment. So rapid endovascular flow is critical. So even if the patient arrives on time, from the time the patient enters the hospital, we need to try and reduce the door to puncture time. And I think this cannot be overemphasized because very often we've seen patients that arrive in the hospital really in good time, but because of the poor workflow in the hospital or because of poor recognition of what the patient has, patient may actually lie in a stretcher and we can lose time when the patient actually has arrived in this. So a great awareness from our emergency departments or any other healthcare worker that may come across a patient with a stroke is really, really critical, so that we make sure that the patient arrives on time, and from the time the patient arrives in the hospital, that from the time they enter the door to the time that they get into our cath lab, we puncture, we go up to the brain and try and remove that clot is absolutely critical, and this cannot be overemphasized. So hence the term time is brain. So if there is one slide out of this talk that you please always have to remember is the slide, that time is brain. Every second counts once a patient has actually suffered an acute ischemic stroke. So what do we mean by image-based patient selection? Firstly, the objectives for early imaging for mechanical thrombectomy, as I've already outlined, we like to see the patient and manage the patient within the window period of 8 hours. That's when really we are likely to achieve very good results. So the first thing that we have to do is to do a non-contrast CT scan to confirm presence of a stroke. And basically to exclude mimics. We know that there are many mimics of stroke. Patient could have a tumor, could be a migraine, could be many other things that may actually present as a stroke. But therefore, it's important to do a non-contrast stroke, which will actually confirm to us that there is a stroke. Once we've confirmed that there's a stroke, the second thing that we need to do is to assess how big is the stroke, the volume of the stroke. And there's a score called the Alberta score or aspect score, which I'll talk about later on, that we use to assess. The smaller the core or the smaller the part of the brain, the better the outcome. Of course, the larger the volume of the brain that's affected by the score, the worse the outcome is going to be. And in fact, this enables us to be able to select the patients whether, in fact, it is a patient that's going to be a candidate for us to intervene or not. Because if you intervene in a patient with a very, very, very large stroke, in fact, sometimes you may not help them, and actually, you may actually make them worse, because those are the patients that might be at risk of hemorrhage due to reperfusion of the brain that is already ischemic. The third thing, of course, as I've already alluded, is to make sure that this is indeed an ischemic stroke and that there is no hemorrhage. Of course, you can imagine if, even if the patient came within 4 hours, if you're considering using any thrombolytic therapy and there's already hemorrhage, you're going to make the patient worse. Or sometimes the patient might have a stroke, an ischemic stroke, but there might be an element of hemorrhage. Once we establish that there is an element of hemorrhage, that's an absolute contraindication to intervention in these patients. And this is very critical. The next thing is to establish whether is there an intravascular thrombus that can be targeted for thrombolysis. You can only treat what you see. And of course, we can only remove clots that we can see that is actually a large vessel occlusion. If we do an imaging, even if the patient has got symptoms, but we cannot find an occluded vessel or we cannot find a target, then really there's no point in us taking the patient to theater, because there's not anything that we're going to be able to do to help that patient. And in this regard, non-invasive imaging, which is a CTA, is absolutely critical once you've established that there is actually a stroke. That helps us firstly to see where the occlusion is, to confirm that in fact there is a large vessel occlusion. And in fact, when we do the CTA, we actually encourage that if possible, we do a scan from the aortic arch right up to the brain, to the circle of Willis, because that also is going to help us, those of us who will be in the theater, to be able to understand the anatomy from the aortic arch right up to the brain. And sometimes patients may present with a stroke, and in fact, you may have what we call tandem lesions, where in fact there's a big clot in the internal carotid artery and another clot in the MCA. And if you don't do a CTA from the aortic arch, you may actually miss big clot in the internal carotid artery, which may be something that's standing between you and that other clot that you're actually seeing on the brain scan. So this is absolutely very critical. And then, is there a core of critically ischemic irreversibly infected tissue? Is there what we call a penumbra, or severely ischemic but potential salvageable tissue? This is not really what we basically do routinely, but this becomes very, very, very critical when we don't know the time of onset of the stroke. For instance, patient wakes up with a stroke, the so-called wake-up stroke. You don't know, patient arrives at like 6 o'clock in the morning in the hospital. You don't know when the stroke happened. Did the stroke happen last night when the patient went to bed at 10 o'clock, or this stroke happened this morning at 5 o'clock? So in that way, advanced imaging such as MRI, where we can actually look at the diffusion-weighted imaging and FLAIR and see whether, in fact, there is a core, and in fact, whether there is actually a penumbra. That helps us to do that. The other way, if we don't have access to MRI, CT perfusion, which is technically a bit more complex, also can be done. But as I say, that we don't do that routinely, but these are the tools that, when, if available and accessible, can help us to actually assess this inaccuracy, and I'll show you some images of this later on. So let's just quickly go to what you might see on a non-contrast CT scan, useful findings. You might be able to see what we call the focal parenchymal hypodensity of the insular ribbon, the so-called insular ribbon sign, or the lenticular nuclear sign, or where basically you get obliteration of the basal ganglia. You can get a swelling of the brain cortex with effacement of the superficial cell side. You can also get what the loss of gray-white matter differentiation. And sometimes on the non-contrast scan, you may see what we call the hyperdense MCA sign. This is an example of an insular ribbon sign. On the right-hand side, you can see the white arrow. You can see that the insular lobe, you can see that insular cortex, you can see that slight hypodensity, and in fact, if you look carefully, there might also already be something already in the brain cortex. But this is the kind of patient that we want to see and that we actually want to treat. Whereas when you see on the other side, you can see this is a much more established stroke. And of course, this patient on the right is going to do much better than this one. So we want to see that. And therefore, it's very important that when we do images, because sometimes these images can be, these changes can be subtle. But this is the kind of what we might be able to pick up when we look at the brain scan. Lenticular nuclear basal ganglia. On the left, this is an example of a patient. For instance, if you look at the basal ganglia, if you look at the head of the caudate nucleus, the internal capsule, the lentiform nucleus on the right-hand side, if you compare this side and you look at on the left-hand side, you can see this blurring of those structures there. That actually indicates that actually there's already ischemia and early swelling there. And this is the kind of picture that really we're happy to see. And we know that this patient, when we revascularize this patient is going to do well, as opposed to this patient when you can see that this already is an established stroke. But this patient may still be, if patient arrived on time, may still be eligible. As I've mentioned earlier on, that sometimes even if you have a core of established stroke, you may find that actually this entire territory is at risk of developing a stroke. And if you intervene, you might have lost this one, but you might be able to save the rest of the brain with a better outcome compared to if you don't do anything at all. This is another example of an early lenticular nuclear, and this one at a much more advanced stage. Cortical swelling, sulcal effacement, loss of gray white matter differentiation, and this is basically an established stroke. You can see that there's actually loss of the gray white matter differentiation. If you look at the superficial sarsa, you can see them that side. Here they're effaced. And on this axial scan and on the coronal scan. And this basically is the kind of thing that we actually see when you do a CT brain. The so-called dense MCA sign on the right-hand side, you can see that on the scan, you can see that, and that actually represents a plot on the MCA, and you can see that brain, there's very early effacement, but once we see this non-contrast scan in a patient that's there in time, this is a kind of patient that we know definitely there's mechanical occlusion. There's a large vessel occlusion, and this represents the M1 segment of the left middle cerebral artery. Or on the right-hand side, you can see a similar sign, of M1 going into M2, because that's M1 there, that will be the genu, and that will be where the MCA bifurcates, and that's M2. And you can see already the changes that you're beginning to see there, that cortical swelling, effacement of sarsi, and already loss of gray white matter differentiation. So this is a so-called dense MCA sign that we might be able to see on an uncontracted scan. MRI, what is the role of MRI? MRI is more sensitive and in diagnosing acute stroke. However, we know that MRI is less widely available. The scanning times are longer, and particularly in a patient that is stressed with scan. But however, it's got a much more sensitivity and specificity compared to CT. When you do MRI, from as early as 30 minutes of the symptoms, we're already able to see changes in the brain, which you might not be able to see. As I've already shown in the previous images, that sometimes the changes earlier on may be very subtle, and sometimes they may even be missed. Whereas MRI, we're able to pick up them much earlier. But unfortunately, the only drawback of MRI and why we don't use it routinely is precisely because there is not really much, it's not really that available, and also sometimes it takes a little bit of time to do. This is an MRI image, this is the image that I've shown you before, showing a T2 weighted image with a FLAIR image showing a left middle cerebral artery ischemia. There's another image, this is a diffusion weighted image showing thalamic and also bilateral thalamic infarcts, bilateral PCA, as well as you can see if you look at this side compared to that side, that is actually the middle cerebral artery on the left-hand side that's already involved. And often when you do a diffusion weighted images, you also look at what you call the ADC map, which as you can see, those are hyper intense on the DWI, and you can see these are hypointense on the diffusion in the ADC maps, confirming that basically there is basically a very significant stroke in this particular patient. So we've mentioned that we have to assess the amount of brain that is actually affected. So size really of the ischemic tissue really matters. And I've mentioned that we use what we call the Alberta stroke program, or the so-called aspect score. Basically, what we do, we look at the non-contracted CT brain, and we divide it into 10 quantitative territories topographically. And it's performed on a non-contrast scan. And this really offers reliability and reproducibility in grading early ischemic changes. And basically, these are just the territories that we look at. We basically, when we look at the scan, we look at what we call the ganglionic level, at the level of the basal ganglia, and we look above the level of the basal ganglia. Basically, you can see there's that anterior the middle and the posterior side, that's M1, M2, M3. These are the lower divisions of the middle cerebral artery. You can see the insular ribbon there. So that will be 1, 2, 3, 4. And then we can look at the caudate, head of the caudate nucleus. That will be the fifth area that we look at, and we look at the lentiform nucleus. So basically at the ganglionic level, we look at those 1, 2, 3, 4, 5, 6, 7 areas and see if there are any changes. And at the supraganglionic levels, we look at that anterior, middle, and posterior part of those different areas. So basically what happens is that we look if there is an area, every area that's affected, out of 10, we -1. So if, for instance, you just have the insular ribbon there and the rest of the brain is normal, this patient will have an aspect score of 9, we -1. If there's a insular ribbon, for instance, in the caudate nucleus, that may be 2, the aspect score will be 8, and so on. If there's a lentiform nuclei involved, that will be 3. So that will be 7. So we keep on minusing that. And basically, the application of it is that the baseline aspect score value predict the functional outcome in symptomatic hemorrhage. So the lower the aspect score, that means the bigger part of the brain that is involved, the higher the risk that the patient is going to hemorrhage when you intervene, and also the higher the risk that the outcome, even if we intervene, that is going to be worse. The score of 7 or less is correlated with relatively poor functional outcome and symptomatic cerebral hemorrhage. Although we are now able to treat patients with 7 score if the patient is relatively young, we see that the patient's got a very, very good chance of, the patients are at a good time. Sometimes we do actually extend a patient up to the aspect score of about 7, sometimes even 6. But being consciously aware that the lower the aspect score, you may not necessarily get the best outcome as you'd get with a score, for instance, of 8 and above. So the other thing, as I've mentioned, we've looked at the non-contrast score. We've confirmed that the patient's got an ischemic stroke. We've excluded mimickers of the stroke. We've looked at the size of the area of ischemia on the aspect score. Now we need to confirm, is there intravascular thrombus that can be targeted for thrombolysis? And that's where we now have to perform a CT angiogram, because non-contrast scan and clinical examination sometimes can actually mislead us. And as I say, that alone are limited in the ability to detect large vessel thrombus. Therefore, CTA has been increasingly advocated as a first-line diagnostic test for patients presenting with signs and symptoms of acute stroke. So what we do in our practice is that we'll do a non-contrast score, confirm the stroke, do the aspect score, look at, and all these things are done in the same setting. It's not a question of taking a patient in and out. While the patient is on the table, once we've confirmed that the patient's got ischemia, we immediately do the CT angiogram to confirm whether the patient is with an occlusion or not. This is an example of a CT angiogram showing, and we can see an area of cutoff there. Just to orientate you anatomically, that's a CTA. This will be basically the left internal carotid artery. That will be the M1 area, and that's the bifurcation of the ICA. That will be the ACA, and you can see the M1, typical kind of case that we see every day in patients that are presenting with stroke, confirming that on these axial scans and on the coronal scan, showing that there's that gap there, represented by a clot. And this is the kind of patient that we may be able to get there, remove the clot, and basically revascularize and restore flow. As I've mentioned, that one other question that we might want to answer, is there a core of critically ischemic, irreversibly infected tissue? Is there penumbra or severely ischemic, but potentially salvageable tissue? This is basically critical, as I've mentioned, for instance, in patients where we're not certain whether we should intervene or not. So when we do this, we can see whether there is, even if we know that the patient might have an ischemic stroke, but once we see that there's a big area of penumbra, what you call penumbra, which I'll show you later on, then we know that even though we know that there is potentially a part of the brain that is damaged that cannot be saved, there is basically a large part of the brain that can still be saved. So basically what the concept of penumbra is that acute cerebral ischemia may result in a central irreversibly infected tissue core, but this is maybe surrounded by a peripheral region of stem cell that is called the penumbra. So basically what's happening in this area is that we've got the evoked potentials in the peripheral regions are abnormal. The cells have ceased to function, but this region is potentially salvageable with early recanalization. So basically this is a dramatic image that, for instance, if this is an area that is affected, you may find that there's area of core, but there's penumbra. So if you don't do anything to this patient, you're going to end up with stroke in this area. But if you intervene in time, the patient may still end up with a stroke, but you'll have saved this large part of the brain. And of course, the outcome in this patient is going to be better if you save this part of brain and have just this stroke compared to a patient where you haven't actually done any intervention. This is an example of an MRI image of a patient I saw recently in my practice, of a patient that presented within time, within 3 hours of suffering a stroke. And this really shows basically in this particular area, they were able to do an MRI. But basically it illustrates how important MRIs can show us in differentiating this. On the top level, we've got the diffusion weighted imaging scans, and at the bottom, we've got the flare imaging scans. And if you look at the area of the insular ribbon there, you can see the signal change there. And if you go on a higher scan, you can see that appear to be a large part of this middle cerebral artery that is actually already affected. As I've mentioned that with MRI, even within 30 minutes, you're already able to see DWI changes. But when you do a flare on the same patient, if you look at that area there, more or less corresponding to that, you can see that this is an elderly patient, of course. It does have other chronic ischemic changes that we can see there. But if you compare that area of diffusion weighted images on here, and you look at this area here, you can see that the flare is relatively still unaffected. So this is what you call a DWI flare mismatch. So that means there is this area that is potentially, if you don't do anything, that is going to die. And as you can see, that if you're able to open this vessel, this is basically reversible. That this patient eventually basically can actually end up with actually no stroke at all. And this basically where the role of MRI, CT perfusion, or what we call advanced imaging come in. This particular patient, this is basically what the patient's angiogram look like. And you can see that it's got a big MCA, in fact, occlusion on the right-hand side. And this is a flow from the left-hand side showing very good flow to the middle cerebral artery and the anterior cerebral artery. And you can see flow through the anterior communicating artery, showing that this clot, not only is it affecting the middle cerebral artery, it's also affecting the A1 segment of the anterior cerebral artery on this side. So basically, this just basically show what MRI can do for us. So I'm just going to show you a few illustrative cases. For instance, this is a patient that we're able to see that arrived in time, 74-year-old female, acute left hemiplegia, last seen at about 7:30 in the hospital. Imaging was completed promptly because the patient was in hospital, and by about within 2 hours, the intervenists were notified. The patient was transferred to us at a stroke center and arrived basically within about 4 hours. And from the time the patient arrived in the hospital to the time that we actually punctured the patient, because we were expecting the patient, we were able to puncture this patient within 30 minutes of arrival. And after 30 minutes of actually, pushing our catheters upwards, we're able to open the vessel after 2 passes. So this is basically the CTA that the patient presented with. This is an elderly patient that has suffered an old stroke previously, so we'll ignore that. This was an acute stroke that the patient presented with in this particular case. And when he did the CTA, as you can see, this confirmed that there was actually an M1 occlusion on the right-hand side. And when we did an angiogram, you could see that there is basically cutoff of the M1 there, and basically the anterior cerebral artery is still open, and we're able to put our catheter there, aspiration catheter, put a microcatheter through which we're able to just do a small run to confirm that we've passed through the clot, and we're able to put a stent through that, and we're able to revascularize that vessel. And this basically we're able to pull this white fibrotic clot on this elderly patient. And as you can see, basically just after day 1, you can see this patient here, just already a small flicker of that leg, but when we went on the second day, the patient continued, as you can see. This is unfortunately a very short video, but you can see the patient was already able to lift the leg, and patient was able to already start improving. And this patient went on to improve, and later on went to rehab and did extremely well. So this basically shows what we can achieve when the patient arrives in time. And this was the post-thrombectomy scan that shows that cutoff that we saw before intervention, and that the vessel will actually revascularize, and that that area of ischemia that we saw on the pre-contrast scan, but you can see that the rest of the brain was not as much affected as would have happened. Had we not opened this entire middle cerebral artery part of the brain would have been infected, and the patient really would have suffered a very, very severe stroke. The second case basically is that one of a basically a iatrogenic stroke in a patient that we actually placed a stent, and this is what the patient presented with. The patient had an aneurysm, and that we actually were trying to treat. And after placing the stent, and suddenly we saw that there was actually cutoff of that MCA vessel, So basically we're able to do exactly the same thing, put our catheter. And if you look at this image here, you can see that there's actually a filling defect in these segments of the middle cerebral artery. And in fact, here, we're actually not on the M1, we're already on the M2. But we have smaller stents nowadays that can go beyond the M1 segment to the M2. And this is basically what we're able to do. And you can see our stent going through to the M2. And basically, this will show you our stent going in there, and our stent that we through the microcatheter as we deploy in the stent. That's our micro stent in that area there, coming in there. I just want to show you that eventually we are able to pull the clot out, and okay, this is not moving. And then after we remove the stent, we're able to do the angiogram. And you can see now the vessels completely opened after we open that. Okay, so this really illustrates really what can be achieved with that, and that's basically what we did. And basically, this was the clot that we're able to actually, just a small clot, and this is basically just a fragment of the clot. Some of it might have actually fragmented and came out with aspiration when aspirated, but this is what we are able to see in that small stent that we actually put in that patient. So basically, just quickly, just to go through the guidelines in terms of the American Heart Association, in terms of endovascular therapy, is that RTPA should receive, patients eligible for intravenous RTPA should receive RTPA, even if intraarterial treatment are being considered. So if a patient comes with a large clot and they are on time, within 4 hours, you can actually start thrombolytic while you're transferring a patient to an area where they may actually be able to receive thrombectomy. Now, patients should receive endovascular therapy with a stent retriever if they meet certain criteria, basically pre-stroke MRS score of 0 to 1, and if they've arrived within 4.5 hours, I think this is very critical. And they should also, we have demonstrated that there's actually large vessel occlusion. And these are basically a clinical assessment of NIH score. I said 6 or 8 and above. The aspect score of 6 minimum and above, those are the kind of patients that are likely to benefit. So we should basically try to reduce the time from the time the patient arrived to reperfusion time. That's how we're able to achieve better clinical outcomes. And in patients with circulation occlusion who have contraindication to IV TPA, as I've mentioned before, and we've established that they've got a large vessel occlusion and they've arrived within 6 to 8 hours, the patient really are amenable to mechanical thrombectomy. And imaging, as I've already mentioned, of the brain is recommended before initiating any specific therapy. We've already discussed that. And basically that should be non-invasive with CT, non-contrast CT, CTA, or MRI in areas where they actually have access to MRI. And CT perfusion and MRI, as I've mentioned, they can be very, very particularly useful when we're not certain whether, in fact, there is brain to save, whether there is actually a penumbra. That's when MRI and CT perfusion come in. And basically, the idea is to try and open the vessels within 45 minutes of the patient arriving. Just last but not least, intracranial atherosclerotic disease. This is a patient that basically presented to us with a very critical occlusion of the internal carotid artery, and the MRI images shows those ischemic changes on the left-hand side in the so-called watershed zone. This is the medial border zone, and it shows what we are able to achieve by basically just placing an ICA stent and basically being able to revascularize that. And that's it. So just a take-home message: time is brain. it's very important that patients are educated, that they recognize stroke signs quickly, and once patients come to us as health professionals, we need to act very quickly, firstly to establish clinically and basically by imaging that the patient has got a stroke. And if patients arrived on time, there are no contraindication, those are patients who will be candidates for thrombolysis. But if we've established that the patient's got a large vessel occlusion, we should try to refer this patient as soon as possible to a center that's able to offer thrombectomy. Thank you very much, and thank you for your attention.
Thank you very much, Prof. Thank you. So I'm going to start with our first question. It says, where do we have these services in South Africa and the name of the hospitals, other than yours?
Well, there's basically, well, let's talk about Johannesburg. Basically, we have established a center in the vet circuit at Baragwanath Hospital. We now have an active stroke unit where we basically beginning to do that. We beginning to do that, we're in the process of establishing that unit at the Charlotte Maxake Johannesburg Academic Hospital as well. So basically for most patients who can go to government, they basically can come to Bara and Charlotte Maxake. But the one that's already up and running at the moment is actually at Baragwanath Hospital. There are a few centers in private that are also offering this unit. Whereas in out of the province of South Africa, I think Cape Town, there is centers at Grooteskier, and I think, I'm not sure if there are centers in the private that are offering that. And KZN, definitely I think there is the availability of this service at the Albert Luthuli Hospital, where there is a established interventional neuroradiology unit. And I think Steve Biko also is now able to offer these services.
Okay. And your facility in private is located?
Well, I hope this is not seen as advertising or punching, but I think it's very important. Basically, this service are available at the Netcare Albertine Hospital, at the Modderfontein Busamed Hospital, at the Millpark, Netcare Millpark Hospital. So at the moment, these are the three hospitals that are actually offering this service in private.
Okay, thank you. From my side, I just wanted to ask this, and I thought it was quite interesting with the latest recommendations coming out of the trials that said that this would actually be the preferred method in patients that meet criteria. As far as you know, what has been the uptake in South Africa compared to your traditional methods of open surgery or any type of surgical interventions? And do you think that also because the access is limited, which is why we have reduced uptake in terms of this?
Okay, so maybe just to clarify things, when you talk about ischemic stroke, I don't think there's really room for surgical intervention. Surgical intervention really plays a role in hemorrhagic stroke mainly, and that will be part 2 of our discussion when you talk about intracranial aneurysms, subarachnoid hemorrhage, AVMs, and so on. The only time where open surgery becomes, something to consider in patients with stroke, it's something that is not performed very, very often. It's really a salvage technique where you do what we call decompressive craniotomy, when basically the brain is so congested, it's infarcted, it's ischemic, and you basically just open up the skull, basically just to relieve the pressure in the brain. But often the outcomes are not very good. The prognosis is often very poor in these patients. I think that's the first part of the question. To answer the second part of the question with regards to uptake of, in fact, even just thrombolysis and thrombectomy, I think this is work in progress. South Africa, we are lagging behind compared to developed countries, but obviously the key issues here, firstly, are patient awareness. We see stroke is a huge burden in our country, unfortunately. But unfortunately, a lot of patients still don't recognize stroke and know that they can actually go and seek help. Remember that stroke also can be regarded as a brain attack. It's something similar basically to a heart attack, or myocardial infarction. The difference between stroke and heart attack is that when a patient's got a heart attack, they've got severe pain and they know they're sick. They panic and they immediately run, to get care. Whereas stroke, it's relatively painless. Patients can suffer stroke without even realizing that they have stroke. Very often we have patients who said, you know what, I felt my limb was weak, I was having slurring of speech, I just took some water with sugar, and people always hope they will get better. And unfortunately, that time, that's when things are getting worse. Sometimes even when people, see them, and they don't even realize that these patients actually need help. So that's the first thing with regards to patient awareness. The second thing is that we still need to educate ourselves as well as healthcare workers that when patients come to us and they've got signs of stroke, that we need to act. It's not time for us to be, wasting time and trying anything. Once we suspect stroke, imaging is critical. As I've mentioned, we need to establish that this patient has a stroke. Therefore, referring a patient to an area where they will have access to imaging is very, very important. Even sometimes when patients they arrive in areas where there's actually imaging, sometimes we need to make sure that these patients are literally red carpeted, that they image quickly, a diagnosis is made quickly, and if the patient qualifies for thrombolysis, that that's considered. And if the patient is a candidate for thrombectomy, that the patient is really referred as soon as possible, because it's a race against time. So these are the things that basically make us not to do that well. But as I say, it's work in progress. And I think with more patient awareness and with more and more of us as healthcare workers recognizing that now there are these, advanced therapies, that can be given to these patients, that we should actually be aware and know that we can actually refer this patient as soon as possible.
Thank you. Thank you for that. I think one of the other reasons for the increasing incidences of stroke in this country is just because of the risk factors that we have in this country with our burdens of diseases and metabolic issues. And something that people always tend to forget is with the higher rates of mental health disorders, the medications that are used to treat this can also lead to such metabolic issues. In terms of your diabetes and your cholesterol issues and atherosclerosis. So I hope all of our GPs are out there listening today.
Absolutely.
We have another question here from Dr. Benny. He says, having in mind that time is crucial in this context, in the case of district public hospitals, what's your comment or recommendations on approach in such patients presenting at these facilities?
Yeah, I think that's a very critical question. And in fact, that really goes to the core of our healthcare delivery system that, unfortunately, we're in a position where these kind of therapies are available at the district level, sometimes even at some higher levels of care. But I think the key is that we, quickly recognize that the patient actually has symptoms of a stroke, and try and refer them as quickly as possible to a higher level of care. I think really I think there's nothing that beats that. Because it's something that at this stage that still requires really quite a specialized kind of treatment, because you need to have either specialist physicians or neurologists, people who are really well versed with the administration of thrombolytics, and even at a more tertiary level where there's actually interventional neuroradiology facilities where thrombectomy can be done. So at the district level, which unfortunately that's where the burden of patients are, I think we need to look at our referral system and to see how we can improve, the flow of patient referrals with stroke. Our emergency services, ambulance services, are also key. In fact, that's one of the things that really also we need to target. With our program at Bara, one of the key stakeholders that, as part of putting the program together, was also to involve, all stakeholders. And I think the ambulance services is also key in this, because these are the people who are going to see these patients often, who are going to recognize that the patient has stroke, and they know where the centers where they can actually send the patients to. So, if a patient is picked up by an emergency, by an ambulance, sometimes it may waste time to send them to a hospital or a center where they may not necessarily get help. But once they know, where the patient can get help, it might even be better to bypass some maybe a lower level area of care to an area where the patient might get help. But there's a little bit of complexity in that. But basically, that's the core of it, that we should basically try and recognize stroke quickly, diagnose it quickly, and refer the patient as soon as possible to a higher level where they'll be able to get help. I hope that answers the question.
Oh, yes. Okay, Dr. Justice, we've already answered you about the role of neurosurgeons in stroke patients. That's for part 2. I saw another question here. Is it advisable, this comes from Musa, is it advisable to give thromboembolytic drugs while patients are in transit to a treatment center before scanning?
Now, you see, that's a very controversial point, but I would say probably it's not a good idea because, firstly, if you haven't imaged the patient, you don't know what the patient has. And I don't think it should be done. Remember that we said that this is an image-based, diagnosis. You need to do the scan in the patient, firstly, to know whether there's no hemorrhage to start with. If you give a Actilase or RTPA in a patient that already has got a bleed in the brain, that patient is going to get worse. Okay, that's the first thing. But I think what is critical is that if the patient has been in a center where the patient has been scanned, the patient has arrived in time before 4 hours, where it's established that the patient's got a large vessel occlusion, and there are no contraindications for thrombolysis, that patient qualifies that we can actually start the patient on lytics even while the patient are in transit to an area where a thrombectomy can be performed. So, and as I've mentioned, I think it's one of the areas that I've actually mentioned in the guidelines that we mentioned that you can actually start thrombolysis in patients that are still going to go and have a thrombectomy.
Definitely.
Yeah, as you can see, the RTPA should receive intravenous RTPA, even in intraarterial treatments are being considered. Yes.
Okay, so we have a quick question here. I think that one's answered though, but it says, can we use empiric thrombolysis in peripheral areas based on clinical suggestions of ischemic stroke? I think we've already answered that is based on a image.
Yes.
Paki, so we've already identified that the province with the scanning is also due to EMS delays and improving of workflows within the hospitals. And I can see that a lot of the doctors are genuinely bringing up the issues of EMS delays, workflows within the hospitals. And this is what is one of the biggest problems we have in terms of time is brain and getting to these patients within such a short time frame. I just want to open up. Are there any more questions from the floor? Do we have any other questions? No. Thank you very much. Thank you so very much, Prof. So on behalf of clinics and everyone who has come in through tonight, I want to thank you very much. And all of us cannot wait for part 2 of hemorrhagic stroke. Thank you so much. I'd like to thank all of you for joining us tonight. See you at the next webinar. Good night, everyone.
Thank you very much. Bye-bye.
Bye.